Are we on? Yes. Hello? We're on. Apparently.
Hello, Dr. Angelini.
How are you?
Oh, we got Scott Lawrence. We have Sylvana Lawrence is on. Dr. Amin is on. Dr. Morales is here. So I think we can go ahead and start.
There's also a dog in the background. All right, we can start if we can hear the voice by Sylvana.
Sylvana is should be able to speak. She's not. She's unmuted.
All right. Then we can proceed.
We can proceed.
So this is a case. Can I start now?
Correct. Let's go ahead and start.
All right. This is a case. I don't know if it is the only one or one of multiple today, but it's a case that presents several issues of very important nature, and it regards, initially at least, a right coronary artery coming from the left with a severe presentation. Let's see if we can summarize the issues we're going to touch. Next. So this is a 53-year-old male with a severe example of right coronary artery coming from the left, especially severe because the right coronary artery and the circumflex basically are coming from the right ostium in a single trunk. So about 50% of the myocardium is at risk. The severity of the obstruction in area by IVUS was found to be 70%, which is at the upper edge of our population of 65 people, 5 patients that we studied with the right coronary artery from the left an intramural course. Eventually, the patient, because of symptoms and positive stress test, had a stent angioplasty in 2005. He did very well until 2009, when a routine follow-up included a positive systemic stress test. For that reason, he had a follow-up angiogram that showed no restenosis, so everybody was happy until 2013. So we are talking about 8 years after the original procedure, when the patient had a flu-like syndrome when he was on the mountains in Colorado and felt short of breath. Initially, everybody was thinking mountain sickness. Eventually, he went back to Indiana where he resides, and he had continuous and progressive symptoms of congestive heart failure and pulmonary edema in summer of 2013. At that time, he was reevaluated by an echocardiogram. They showed that the ejection fraction that was previously 62% had gone down to 10%. He came to our care again, and we did a biopsy besides proving that the right coronary artery as well as the left were okay, that it was not a coronary problem. And the biopsy was negative for myocarditis. That was the working diagnosis. So because of such a low ejection fraction and a diagnosis of flu-related myocarditis, we put him on the list for heart transplant. He decided to go to the Cleveland clinic that was closer to his house, and he was enlisted for 5 months. Eventually, 5 months after, he was studied again routinely while feeling much better. He had gone from functional class 3 to 4 to 1 to 2. And the ejection fraction was found only at that time in February. In December it was still 22%. It was found to have 40% ejection fraction, and it was taken off the list for transplant. So these are the problems that we want to discuss in detail, because it's quite a dramatic presentation of a subject that we have been quite interested in for some time. Next. So at age 53, only at that time, the patient starts having chest pain and dyspnea with exertion, and he increased the function of class 3 when he had a nuclear stress test showing inferior ischemia. The doctor in Indiana looked around who had more experience. He was seen initially at the Cleveland Clinic. They said, no, we never operate on these situations. And they did the CAT scan angiography and found the right coronary artery from the left at that time. And at the Mayo Clinic, they said, no surgery, medical treatment will do it, beta blockers. Eventually, he came to Houston, and we reevaluated the situation, as you know, with the idea of finding out the severity of an obstruction that we always found in right coronary arteries coming anterior to the aorta from the left sinus of Valsalva. So we decided to go ahead and call him to Houston for further testing. The past history was positive for hypertension of recent onset, old smoking until 10 years ago, hyperlipidemia, mild and controlled. And in the CAT scan, besides the coronary anomaly, they found also extensive calcification of the proximal left anterior descending. So at this time, we were interested in especially studying the right coronary artery, but obviously rule out also that the LAD could have part of this problem explained. Next. It's interesting from this first presentation, delayed, this coronary artery we claim is the reason for his symptoms and the positive stress test did not manifest until this age, which is quite impressive, but a typical case of severe stenosis, as we see, is where we learn the most. Left ventricular ejection fraction at that time was 62%. The right coronary artery was covering the inferior wall and the obtuse margin wall of the left ventricle. They call it superdominant there. We call the origin of the circumflex from the right with a posterior course. The left main, in this case, is more the right than the left main anatomically correct, anatomically described. The left coronary artery went basically to the septum and the anterolateral wall, but not the posterior wall. So it's a sort of a balanced circulation, but a much larger right than usual. So we did the IVUS in our lab, and the right coronary artery mid-diameter was 4.2 by 4.4. We're going to see some pictures of this. And the area was 14.5 millimeters square. The ostium was intramural, laterally compressed, mildly hypoplastic, but had a valve luminal area of 4.4 square millimeters. That led to the diagnosis of a critical or 70% area of stenosis in a superdominant right coronary artery. Next. So discussion with the family and the patient obviously ensued, and we came to the decision to go ahead and do at the same time a stent angioplasty. And in 2005 was sort of very much an experiment, but it was what was reasonable to try. A significant stenosis, a supradominant right, but still a right. It was a good target for a procedure with diastolic pulmonary circulation. He preferred that after being off for surgery too, and we did it at the same procedure. The guide wire 0.14 was I think it was a run through. A stent cipher that was the most fashionable at the time, 3.5 by 18 with the intention to go to a higher size. 4 millimeter diameter was the target, and it was dilated with a 4.0 non-compliant balloon quantum at 18 atmospheres that brings the balloon size to 4.2 millimeter diameter. There was no apparent residual stenosis, neither by IVUS nor by angiography. From the beginning, it was obvious that the balloon is not enough, even at 4.2 diameter, to expand the stent to touch the long diameter of 5.2 millimeters. So there was some hesitation or anxiety leaving an unopposed stent in one direction. But with the strict regimen of follow-up, we thought that it was a good idea to leave him alone with the Plavix for 6 months. At that time was the recommendation, and now is for 1 year, and see how clinically he was doing, and following year by year with a nuclear stress test. The patient then was kept on Ecotrin 81, Plavix 75 for 6 months, metoprolol 50, and Lipitor 10. Next. In the first 4 years, nothing happened clinically. The patient had no more chest pain or dyspnea. He was in functional class 1. He had a beautiful career as a president of a large metallurgical company in Indiana. And at the routine follow-up, a nuclear stress test showed a milder than preoperative, but a mild inferior reversible defect. There raised some question about stent restenosis. He was referred back to us for a restudy, and there was some anxiety here about restudying a patient with a stent that was mildly bulging at the origin of the dominant right coronary artery, as the ostium was slit-like, so we usually leave 2 millimeters of unopposed proximal stent. So the patient came for a restudy that included also IVUS, and we're going to now show the first movie when the stent was put in, and the second movie and the IVUS at the follow-up when the evidence of restenosis was only a positive stress test movie. Any questions until now? Is anybody there?
No questions.
No questions. All right. So this is the preoperative movie, and it's a non-dominant left. You see this system, the LAD stops halfway to the apex. As a large first septal, the LAD is very small. It seems to be split with the first diagonal. There are two diagonals, and then a small ramus, but nothing else. There is no tooth marginal from this side. The origin of this left coronary artery is a little higher than the sinotubular junction, but it's still normal. Next. In another view, you see the calcifications in the left main. It's a long left main with a very thick calcification of the main trunk of the left coronary artery. As you see, this is another coronary anomaly that we called in the literature what is named ectopic, abnormal origin of the circumflex from the LAG with an acute angle. The circumflex is small, and it is at more than 90 degrees angulation, goes backwards. The LAD, the circumflex usually comes from this, from a splitting of the left main. This comes from the LAD and goes backward, and is small. The right coronary artery covers the rest of the territory of the left ventricle. This is again a large first septal and an LAD that doesn't reach the apex. This is an interesting picture that I frequently take, not because it's very difficult to enter selectively into the right coronary artery, but because it's useful to see the sinus of Valsalva and in a non-selective approach, the origin of the right coronary artery from the left. You see this spike here? The spike is the origin of the right coronary artery with the circumflex, that the ostium is very compressed. It's quite small. As a matter of fact, we will see in the diagram that is smaller, the lumen is smaller than the size of the IVUS probe. The IVUS probe, the Boston Scientific that was used in this case, or the Volcano, are 1.3 in profile. So we learn in this case, but in others too, that sometimes the IVUS itself, the probe, can maintain the ostium of these coronary arteries that are intramural open artificially with the IVUS catheter. You understand this point of the left main? This is very important. The right main, it's a right main coronary artery, is quite obstructed at the ostium, and next to the left sinus of left ostium, left coronary ostium, you see they are both injected at the same time. Next, this is the most beautiful picture of the anomaly. This is another similar picture that shows you very nicely. Now we have a catheter that was designed for this type of ectopic origin. It's a catheter we designed, and Cordis in Florida made for us, a custom-made guiding catheter. Has an anterior tilting of the distal end of this guiding catheter. It's a 6 French guiding catheter. It is next to the ostium, but you see a non-selective injection show you without entering into the artery that the coronary guiding catheter may have to open by its presence the coronary ostium when there is an ectopic origin, a tangential origin, to be very selective. So this is a volcano, actually. This is the typical volcano appearance of an IVUS catheter. This is the same. Now with the guiding selective. You see at the beginning of this artery, you see not stenosis in this view, but enlargement like ectasia. This is the 5.2 diameter, larger diameter, while in the previous right anterior oblique, you see where it is less than 1 millimeter in cross-sectional diameter. So this is a typical anatomy. The distal right coronary artery that is ending here continues into the obtuse margin of the heart, so it's a very large right coronary artery. At this point, we start describing and at the same time measuring where to deliver a stent, because this is very critical and difficult, and we are planning to do a demonstration course to show what can be done to optimize an unusual and difficult deployment of a stent to take care of osteostenosis in these cases. The guiding catheter has to be necessarily outside the ostium, but we need to be precisely aware of where the coronary artery lumen, circular lumen versus partial lumen in the slit-like orifice, part of 2 or 3 millimeters proximal are outside the true coronary artery. So we are taking different projections. Here you have pictures that now show you where we decided to leave. As we have to push, the guiding catheter tends to come out, so it's a very tricky procedure. At this point, we thought we were in the right place. This is where the ostium of the slit-like ostium of the right coronary artery starts, but 2 millimeters are outside by IVUS, and the rest is in the intramural segment of the right coronary artery. We decided to advance a little bit. You see, this is the right sinus of Valsalva, where obviously the coronary artery was supposed to be. It would have been normal to have an ostium of the right here. All this segment, these are 18 millimeters, are intramural. Now we are close to perfection, and you see here both the ostium of the left and the ostium of the right, and we deliver the stent in the next picture. That's exactly where we finally came to, in 2 different projections, to the determination of where to put it. Now there is a stent here. You see, from here to there is a stent, and now it becomes critical not to be too aggressive with the guiding catheter, because the guiding catheter, if it's pushed too aggressively, can collapse the stent and create a lateral progression of the stenosis. So it is important to be there with IVUS, because IVUS is really the way to size the stent for the final deployment. So we put a larger balloon. This is a 4 millimeter balloon inflated to 18 atmospheres. And finally, the final picture follows. Now it's a very large stent with 2 millimeters, the proximal at 4.2. And we are going to see, this is again the ostium. And this is the end of this procedure. The next is the second procedure, and it's the left coronary artery. At the time of the positive stress test, the ostium of the right coronary artery was not selectively engaged yet, but the guiding catheter is able to go to both coronary arteries. This is a left amplatz with an anterior tilt that can go selectively in the left, and by torquing anteriorly into the right, it will go selectively, as we're going to see in the right. The stent did not move since the original procedure. In this projection, you see very nicely that the cross-sectional area of the stent is perfectly round, so there is no problem of collapse or lateral compression that sometimes is claimed to be an objection to use this technique of proximal right coronary stent. This is still non-selective. Here is more selective. Now you can see pretty well that there is no filling defect and no evidence of stenosis. It's a large proximal artery, like you can expect with the lack of apposition. You see that the stent is not opposed to the upper end of this that in this projection represents the long diameter. This is more selective. Gradually we came over the IVUS probe, more selective without distorting the stent, and the IVUS is there now, and we show the picture of the follow-up in the next images. This is the distal right coronary artery. You see 1, 2, 3, 4.2 millimeter in size. Actually, this can be shown until the end. At the end, you will see appearing the signs of a stent. This is intramural already. This is the anterior cusp of the aortic valve, the anterior commissure, and this is the stent, widely open, minimal amount of scar tissue. This is less than the 0.2 millimeters. The size is good. There is a little bit of systolic compression, like some persistence of the systolic and diastolic variation in the cross diameter persists. But this is a wide open stent, definitely no evidence of restenosis. This is at the ostium, and this is the guiding catheter. So this, we did it again because we had the sensation that this could have been a localized restenosis tissue, but it was the end of the stent. There could be a little bit of a stent opposed outside the unopposed stent to the wall of the right coronary artery. So let's go back and go to the story. As you can imagine, we could reassure the patient at that time with IVUS and angiography that the positive stress test was not really a sign of a restenosis, and it was related to a diaphragmatic artifact, and we recommended to do the nuclear stress test yearly on a prone position to eliminate the diaphragmatic artifact. As he was a very busy president of a large industry, he became quite anxious and under distress from a lawsuit, major problem, federal tribunal guessing that there was some responsibility of theirs. So he was in some level of anxiety when he decided to take a skiing trip to relax and enjoy life before the final effort. He went to 11,000 feet. He felt short of breath. He had coughing. He had something like a flu, but not mild, not severe. But it was prolonged. It would not stop. He has no history of alcoholism. And when he developed progressive shortness of breath and was admitted to a local hospital, he was found to be pulmonary edema. He was given Lasix and to see electively as an outpatient and cardiologist, so people were not very alarmed, but the presentation was serious. At that point, he was left for a few days only on Lasix, and he lost 30 pounds. At that point, he made a little investigation of what could be done and not be done. The EKG only showed incomplete left bundle branch block, but no signs, no symptoms of chest pain or myocardial infarction. So he came to Houston for another reevaluation. We are now in August 2013. It's 3 months since the flu-like symptoms and the starting of the shortness of breath and dry coughing. On physical examination, there are no signs of congestive heart failure with Lasix every day. He had muscular wasting, and he had lost 16 pounds since 6 months before, when he was baseline in optimal weight. He had S3 and S4 gallop sounds, but no murmurs. On echocardiography, there was less than 10% ejection fraction, 8%. He had diffuse uneven hypokinesia with an inferior akinesia, question mark. But definitely there was a sensation that beyond dilatation there was uneven hypoakinesia. The pulmonary pressure that was previously normal was 40 millimeters of mercury. There was a 20 end diastolic pressure, and there was a V wave on the wedge in the range of 20-25. There were no arrhythmias by Holters, and that was important for the discussion if he needed to have a prophylactic ICD. And coronary and left ventricular angiography confirmed the presence of an ejection fraction of less than 10% with diffuse uneven hypokinesia, moderate mitral insufficiency actually by left ventricular angiography, moderate diastolic dysfunction with 20 end diastolic, no coronary obstruction, patent stent. The IVUS was not done as he was so compromised and we didn't want to run any risk of precipitating a serious crisis, but angiographically there was no evidence and the flow was perfect in the LAD as in the right obtuse margin. The medical treatment was upgraded, including carvedilol and ACE inhibitors, with the idea of increasing gradually the medication as tolerated. And the idea was to reevaluate the patient in 3 months to decide if to put an ICD or not, but enlist the patient in the transplant center for probable a need for a heart transplant. When he went on, he came to the decision to go to Cleveland Clinic to be in the active list for transplant. At 3 months before committing to ACD, he had a cardiac MRI with the late gadolinium enhancement to see if there was evidence of any scar. And there was no evidence of scars, but only evidence of diffuse severe congestive cardiomyopathy with dilatation, diffuse, uneven, and moderate MR. Ejection fraction in November was already 22. There was opening some hope, but not really a significant recovery. But from 8 to 22 is more than double. It's retrospectively a very good indication of what is going to happen, even though for a myocarditis is rare to see such a slow progression. So we decided to hold the ICD, follow up for a little more, and the next was 3 months after to do another echocardiography in Indiana, and the same night the doctor called saying that the patient was totally different than before. The ejection fraction had increased to 40%. He had improved in muscular mass and in the congestive failure. He didn't need any more diuretics, and he was just on Coreg and lisinopril. The left atrial size is a good measure of the amount of heart failure. Had gone down from normal, from 4.4 with the heart failure to 3.3, which was the normal before. And left ventricular end diastolic diameter was initially with the pulmonary edema 7.0, major dilatation. It was only 5.8, which is a dramatic improvement, even not normal. The left ventricular end systolic diameter was 4.6, and the thickness of the ventricular septum that had gone down to 9 or to 10, now it was 10.7 millimeters. Next. Now, let's go back to see exactly what we are meaning by this condition. The coronary cross-sectional lumen, when we say 70%, is something that really is not a fixed number. It is about 70% as an average, but it could be as severe as this is the end systolic luminar area, 2.2, which would be 90%. Or this is 5.2, it's something like 45%. So it's what we use now is an average and is science in evolution. We don't know exactly what to call the severity, but these are the variation in area, and this is the variation in the important diastolic, cross-sectional diameter. This is the short diameter, the one that pulsates in systole and diastole. In systole is the lowest, so it's 0.7, and in diastole is up to 1.8. So this is the variation in cross-sectional diameter. The longitudinal diameter doesn't vary much. This is the EKG. So this is, we're talking about this segment of the right coronary artery. The stent was put from this position to this position. We didn't cover completely to the ostium, and there was minimal narrowing at this level, but it was 18 millimeters in length. So very serious. This is the aortic wall. This is intramural and compressed and hypoplastic. So now we're going next to conclude and offer the material to your discussion. We have a case of a severe right coronary artery from the left, severe both for the extension of the myocardium at risk and severe because of the stenosis, with these features of systolic diastolic variation. The dominant right coronary artery is as important as severe stenosis in diastole or in systole. It is important to recognize in this case the late onset of angina and positive stress test in a patient quite active, skier in the past and up to that 2009 vacation. And obviously something has occurred in the evolution of this condition that is claimed to cause sudden death only in the early stage of the disease, but unlikely related to the stent. But the symptoms appeared with this congenital anomaly without atherosclerotic addition. There is no cholesterol deposit. There is no atherosclerosis inside the wall of the aorta. The wall of the aorta is deprived of the intima. There is only endothelium over the media of the aorta. And apparently, this is the best condition to prevent atherosclerosis. Unfortunately, it's not the best condition to have a round lumen of a coronary artery. So late manifestation of angina and positive stress test. Initially, this is a very good result of stent angioplasty, but unfortunately the patient, in our discussion and conclusion, had an episode of myocarditis. It could have been a toxic fume of some kind in this industry, but we could not come up with any hypothesis. And it became critically sick in a reversible manner. We hope it will continue to improve. 40% is livable, so it was canceled from the transplant list, but it's not normal, and we are not super anxious like we were before finding out that the right coronary artery is open, but we are still expecting and hoping they would have a complete recovery. So at this point, the discussion is open for all this material that I'm sure is new to the majority of the audience, and I hope that Silvana is there and can also present her objections, as she is quite uncertain about the future of stent angioplasty in this condition. I was reminded that I didn't show the left ventricular injection, so let me, while you prepare your questions, let me present the last picture. This is typical cardiomyopathy type of coronary angiography, diffuse narrowing of the left system, very severe narrowing. One of the discussions we had was if this was a case of Takotsubo, but it lasted so long and it never recovered to normality, so the story is not sustainable as a Takotsubo. But this is something that occurs in the early stage of Takotsubo too. There is at least a couple of cases of global Takotsubo in the literature. Somebody said this could be one, but evolution is not of Takotsubo. This is still the left. It's a very small system, especially with this diffuse narrowing. Next. And this is the left ventricular angiography. As you see, at the time of the initial study after heart failure presentation, the severity of hypokinesia or inferior is almost akinesia is quite impressive. It's difficult to see left atrial filling from mitral regurgitation, but I assure you that by echocardiogram there was significant. We took several samples of right ventricular myocardium, and we did an injection in the right that showed that there was a right ventricular involvement too. It was not only left ventricular cardiomyopathy, but also right. There. This is the right coronary artery. Next. There's another right coronary artery is better. You see the stent very well there. And you see the part of the stent is outside the vessel defined as a circular wall. But this perfect location, there are 2 millimeters outside, and there is no evidence of stenosis. If the patient had the thrombosis, and considering the possibility that this occluded temporarily and then resolved, but nobody gave thrombolytics to this guy, this would not be the pattern of hypokinesia. This is a very diffuse, involving both the right ventricle and left ventricle hypokinesia, but it's quite unusual and difficult to explain, if not as a cardiomyopathy. And myocarditis can be patchy, uneven. Any questions? Is anybody there?
Hello?
Hello? Yes, Eric?
Hey, we're here. We're here.
Oh, how are you?
Savona, can you speak? I think we've unmuted you.
I finished talking. Did you listen to all the presentation, or we missed it?
Yes, sir. We were here for the whole presentation.
Okay. I don't have any further questions or presentation to make. Do you have any questions or objections or alternative hypotheses?
Is stenting your first approach for these kind of lesions?
We run for 10 years, actually 13 years. The first was in 2001, we tried to take care of patients that we decided were severe enough as to justify an intervention in patients that were willing. We decided to use this in place of stenting, in place of unroofing. There is the normal procedure previously done and still done at this time. In our experience in the last 12 years, we reviewed the total number of right from the left in adults, and it was 250 cases, of which 60 went to surgery. Most of them were reviewing this experience with more precision, but most of them were done because they had associated other anomalies of the coronary arteries, especially coronary atherosclerotic obstructive lesion that needed bypass surgery, and or valve replacement, bicuspid aortic valve, and so on. But we did, out of these 250 cases in our hospital, only 36 cases of stent. 36 cases, and we studied with IVUS 62. So basically half of the patients with significant symptoms to justify a study with IVUS eventually were done with this. But it was not in a randomized prospective study. It was an empirical pilot study. And at this time, we are very positive and hopeful that this will become the standard treatment for right coronary artery coming from the left with significant symptoms or significant ischemia on testing. But this is a sort of an experimenting course. It needs to become a multi-center, consistent prospective study, and hopefully with randomization to surgery. But this is not the case yet. It is our initial pilot study.
And of these patients that you're stenting, do you have good long-term follow-up on them? And how are you following them with yearly nukes?
Yeah,
Cath?
Yes, a good question. This is exactly what we're doing at this time. The follow-up is mandatory every year until at least 10 years, and is done by symptoms, stress testing, tendentially or mainly in my patient only nuclear stress test. At this time we do PET scan in all of the patients. The restenosis rate at this time is 14%. That includes 3 restenoses in the early cases that were bare metal stents. So in the other patients, there are 90% of the stents, of drug-eluting stents, there was 1 restenosis only.
And how does that relate to some of the surgical alternatives as far as morbidity, mortality, follow-up?
Very good. Not many cases are reported, a series of importance, but a few studies are in the literature, and there are at least 2 major multi-center database projects to unite the experience of several cardiovascular surgery centers. At this time, the reports are not conclusive, but the follow-up is scanty, is usually clinical and stress testing. There are some, I think 24% of positive stress tests without symptoms, and something like 5% or 6% of symptoms recurring, fairly atypical, so nobody knows exactly, but nobody has done any IVUS in these patients. So If you do even angiography in these patients after unroofing, you will not know if there is restenosis. You need to do IVUS. CAT scan will tell you where the coronary artery that becomes free after unroofing starts, where the ostium, the new ostium is. So you can have, by CAT scan, an indirect evidence that there is no residual intramural stenosis or a restenosis they need to do when they do unroofing of the proximal right coronary artery. They need to do a sort of continuous suture, and that can cause a restenosis. So the follow-up is mainly clinical, and the amount of infarction is 1.5. The positive stress test, but mainly electrocardiographic treadmill test, is in the 20% range, but the quality of follow-up is very poor. If we do a multi-center study, it should be done with IVUS before and after, even if at the end surgery should be the preferred technique of the intervention.
Thank you. Thank you. I'm just trying to figure out how we should follow up these patients and what's the best management for them. It sounds like if there's no complications, meaning bicuspid or other congenital anomalies, that maybe stenting is the way to go.
Yeah, if you have, technically, if you have the proper technology, which means essentially a guiding catheter specifically designed for this eccentric fish-like or fish mouth-like slide tangential origin. If you solve that problem with a special catheter, this is a very simple procedure. After you do IVUS, it takes 15 minutes to complete. So it's a very attractive procedure, but that's my worry, that if people start becoming confident with the method, eventually they will disseminate without proper follow-up, and the follow-up is essential, especially in the beginning years when we don't know what the possibility is in terms of restenosis. At this time, an early series is very hopeful, but we need to go with nuclear stress test, because restenosis will be picked up by significant, which means more than 60-70% stenosis. The PET scan, 50 to 60 is already an 80% predictive quality of the test, so it's a very good test to follow these patients. But surgery also needs a more strict follow-up.
In the form of SPECT or TET stress testing that you're suggesting, is it pharmacologic with dobutamine or with vasodilator?
At this time, we do PET scan with pharmacologic adenosine or similar. And it is because it's done in a single session, so the patient remains for 45 minutes on the table and is finished with a single injection, and he will eventually come up with what is stenosis when you increase the flow by 2.8 baseline, the 2.8 times the flow of baseline. So it's an equivalent stress to a moderate exercise. The typical submaximal exercise goes to that level of increase in flow rate. In the past, or even in the present, the preoperative stress test is less than ideal with an adenosine stress test, because there is a component of increased output in the increased severity of obstruction, especially in kids or athletes, and we prefer maximal exercise with a sestamibi stress test.
What about dobutamine, where there's some thought that maybe the increased contractility, pulmonary dilation may have some impact on that?
Okay. there are 2 points in this regard. One, the mechanism is not compression between aorta and pulmonary artery. It's only intramural aortic pathology. Is the wall of the aorta that enlarges with the systolic phase of the heart, and when it expands, it tends to compress the intramural segment of the proximal right coronary artery. So the pulmonary outflow, the pulmonary enlargement that you can expect with exercise doesn't really create any further problem. It is the problem of the aortic expansion with exercise, maximum exercise then is more important than a vasodilator. And yes, you're right. Dobutamine has the capacity of increasing contractility, increasing cardiac output, increasing heart rate. So basically is a suboptimal but fairly decent in kids. It could be better than adenosine, especially in the preoperative. But we don't usually use, because in adults especially, is much more predictive to do a maximal stress test on the treadmill and do the nuclear under those conditions. An athlete can increase the cardiac output to 25, 30 liters per minute. At that level, the aorta dilates much more, and the heart rate goes to 200, 210. At that level, the amount of systolic time that there is more stenosis, it's much more than at baseline, when majority of the time is diastolic time. So it's a much better flow, because the majority of the flow into the left ventricle is in diastole. So there are advantages, especially in the preoperative selection time, to use a maximal stress test and not submaximal and not adenosine.
Hello, Paulo. We have Savannah. Savannah has a question. Can you speak, Savannah?
Dr. Lawrence.
She may have some problem with her mic or something. I was going to ask you, Paulo, have you ever heard of patients getting high altitude sickness, decreased coronary reserve, and having previous cardiac problems that results in myocardopathy or some permanent damage that takes a while to reverse, long time to reverse?
Yeah, we have studied high altitude sickness, and the conclusion, as far as I know, and we had an authority in this medical center by the name of Jim Alexander. He studied people on Kilimanjaro, including himself. He brought there a cath lab and an echocardiographer. He came to or everybody in the subspecialty came to the conclusion that the problem with mountain sickness is increased capillary leakage of fluid, pulmonary edema from a pulmonary condition, and not a left ventricular failure. The doctor, they went to the Kilimanjaro, had the Holter monitor, and he had several spells of ventricular tachycardia besides atrial fibrillation. He was already in his 60s, and he got scared from the arrhythmias more than anything else. But Kilimanjaro is 5,600 meters where you get, even if you are not very well trained, but to high altitude, but if you are very persistent, it's a major effort. And the arrhythmias are quite disturbing. The patient never had arrhythmias at baseline, but high altitude causes both atrial fibrillation and ventricular tachycardia.
Yeah, I guess we have to come up with some theory of how the high altitude resulted in myocarditis, and you'd have to think about some of your favorite things like coronary artery spasm, or hypoxemia, decreased nitric oxide. I mean, obviously this is a guy who has pre-existing heart disease. It's not entirely normal. And so perhaps there's some insult that occurred as a result of that.
I would think, Eric, that if that was the mechanism, it would be quickly reversible. This had at least 6 months, or at least probably it will continue to improve for 2 or 3 more months. A very slow, progressive improvement that is not like nitric oxide failure or any other functional transient effect. This must have been either myocarditis from a virus, or it doesn't say that he had drunk anything unusual, but something like cocaine or alcohol at high dosage can cause this.
And he was treated with beta blocker, ACE, spironolactone, etc.
Right. He required diuretics, quite surprisingly, only for a few, maybe 2 months. Eventually became comfortable at sea level, basically, without diuretics, just carvedilol and lisinopril. Quite surprising.
So we've had a lot of patients that have been put on the transplant list inappropriately, who responded in the 6 months to 8 months, up to a year.
You're right. You're very correct. We have seen too, especially myocardiopathy of tropical origin or myocarditis of viral origin. They are sometimes reversible in more than 3 months. There is the typical time where you make a diagnosis of irreversible cardiomyopathy from infections. But in the usual myocardiopathy from coronary disease, you don't see those results, and they are stellar.
Now then we have a group of patients that reverse with an LVAD after a couple of months of LVAD, and then you can wean them back off the LVAD again.
Yeah, here there is a group that did that both in animal and in patients, and the results of unloading a patient with an acute failure is more promising than in a chronic stage of cardiomyopathy. In the acute stage, even if it is typically it's postoperative coronary bypass surgery after an infarction complicated with shock and pulmonary edema. In those patients, if you unload from the beginning with a temporary transeptal pump or an apical ventricular bypass, the results are promising for this type of early reperfusion after infarction, but for chronic scars, it's very unlikely, and it's basically the same results they can expect with medical treatment.
I'd like to say a few words about the SPECT scan, in that Blue Cross and Blue Shield did a study of Michigan and found a 40% false positive rate, 65% false negative rate. And we had a patient from Indianapolis who came down here who had a false positive SPECT scan there at Indianapolis at the IU, Joe Noble, and got a cardiac cath, and then wound up having some cardiac calcification, and it turned out to be histo, and then wound up getting another SPECT scan, and a total of 100 millisieverts of radiation, and within a year, hanging around the cardiologist a little too long. And so we wonder why you won't consider perhaps Lexiscan MRI, which for perfusion studies, which Dr. Morales prefers, our cardiac PET from your friend Dr. Gould down the street there at Herman, rather than the renowned SPECT scan that has so many problems because of attenuation, both the stomach in males and breast in females.
You're quite correct, Eric, and it was in collaboration with Dr. Gould that we came to the decision to change 2 years ago from SPECT to PET scan, and we are very, very happy. All the inferior diaphragmatic artifact disappeared. The breast artifact also are much less. The artifact from the colon absorption of radiation remain actually, but a much lower level of false positive. False positive maybe, false negative is not.
Dr. Morales has been gaining experience using Lexiscan cardiac MRI perfusion, and he's been very enthusiastic about the results of that and the lack of artifact.
Very good. We are too. We are totally in agreement that it's a worthy transition to make. And it's funny that now Medicare pays better for PET scan than Sestamibi.
That's correct, they do, although we haven't been able to get a lot of people to switch. It's very difficult to get hospitals, universities, to get cardiac doctors' offices to switch from SPECT, which they all know the false positive rate, but I guess everyone thinks they have the expertise to read around the artifact. And then the monetary reimbursement is seductive. If you've only spent $100,000 for a rebuilt SPECT unit that you have in the office.
You're right, Eric. You know, in our place, the last time I looked at this phenomenon in the cath lab, we found that 30% of the people studied was for a false positive nuclear stress test, Sestamibi most of the time.
That's not bad because University of South Florida, we had an 80% false positive rate. In Ontario, Canada, it's an 88% false positive rate up there in Ottawa, a conclusion based on 9 hospitals.
Yeah, it is a big problem, and I think PET scan is mature for clinical usage and is very useful technology at this time.
Certainly frustrated to people like me and Lance Gould, where we can't seem to correct this or change the industry because everyone thinks that all the procedures are like what Dan Berman has in Cedars-Sinai, and some of the other good guys like Franz Walker's, and so they think that's the gospel. But it turns out in the real world, we don't have specialized nuclear techs with body proppers, and so it's physician supervised, just the exercise, and inject the Sestamibi and leave, and then the procedure's done. And so I talked to my attorney about that. He said that's not fraud. It's not. It's actually just bad medicine.
Yeah. I think the problem with the PET scan now is mainly with private payers, not with Medicare or Medicaid.
Yeah, we pretty much get everyone approved as a known entity that's been doing it for like 10 years, and so we pretty much get approved from all the insurance companies because we met with the radiology benefits managers and had them come down here and establish our fact that we're valid workers and that we don't own the scanner and we're not picking up the money with a Brinks car every day.
Very good. Is there anybody else that wants to present a case?
We should have a case pretty soon. We don't have one today, but we have a lady that's referred to us, and we'd like to show her. Hopefully next time we'll have all of our multimodality imaging ready for you. We may need your help with an IVUS.
Eric, the extra bonus that we're going to give tonight is that CNN announces that the Chinese have found debris of the airplane in Malaysia.
They found it in Malaysia?
No, close to China.
Oh, close to China. Malaysian Airlines been found in the water, I guess.
I guess so. No, we don't know yet.
I see. And Crimea belongs to Russia now, right?
Something like that.
Well, I've been there, and there's really nothing worth having down there, or nothing worth even fighting over. The valuable part of Ukraine is the dark soil in the middle of it, so we don't have to worry about Crimea.
The only value is to have a port for the fleet, the military fleet of the the Soviet Union.
Well, the port called the fleet isn't so useful because it can be bottlenecked at the Strait of Bosphorus, so it's not a very good outlet for them. They're stuck anyway. You can stop them the next stop point.
You're right. Dardanelli.
Okay, well, thank you so much, Paulo. We really appreciate your presentation. I'm sorry Dr. Lawrence couldn't speak. I think she was having trouble with her mic, but we'll be hearing from her, I'm sure. I'd like to thank my student, Shetta Amin, a medical student, for attending today, and I hope that she enjoyed it. We will post this and have it available for Dr. Tobis and others if they'd like to see it.
Very good. If Silvana is listening, thank you very much. I need to talk to you.
Thank you so much. Have a good week. Bye-bye.